Good morning, everyone. For those of you I haven't met, I'm Jen Clays, the Division Director for Newborn Medicine, and it is my distinct pleasure to introduce our speaker for Grand Rounds this morning. Dr. Misty Good is the Division Chief of Neonatology and a tenured Associate Professor of Pediatrics at the University of North Carolina at Chapel Hill. Dr. Good received her medical degree from the American University of the Caribbean and completed a pediatric residency and a chief residency at the Children's Hospital of Illinois. We were then fortunate to recruit her here for her fellowship in neonatal perinatal medicine, where she began her research work under the mentorship of Dr. David Hackham. Dr. Good's research work focuses on necrotizing enterocolitis, also known as NEC, and her now internationally recognized lab has an outstanding record of funding support and publications. She has received 3 NIH R01s, an R44, a DP1 Innovator Award, and a Chan Zuckerberg Initiative Award. She has published over 100 manuscripts in high-impact journals and has identified a possible new immunotherapy for NEC, which has been patented for use in premature infants. She is also the founder and director of the NEC Biorepository, the largest biorepository of samples from preterm infants in the U.S. In addition to her own research work, Dr. Good is committed to fostering the development of the next generation of pediatric researchers and hosts a new incubator podcast called At the Bench to support early career physician scientists. Please join me in welcoming back Dr. Misty Good.
Oh, wow. It's so good to be back. I can't even tell you. And I'm just truly humbled by the opportunity to tell you all about the work and what's been happening since I've been gone. But actually, I just want to take a quick moment. How many, do we have any residents in the room? Raise your hand. Don't be shy. Okay, great. And then fellows. All right, great. So I'm going to take you on a journey of my career, mostly so y'all know I couldn't even pipette when I was a fellow here. And so it took a lot to get me to this point. And thank you to Jen for recruiting me to be a fellow here. And it was just the most amazing experience. So I'll tell you all about our research on necrotizing enterocolitis and really the journey along the way. As Jen mentioned, we've been really fortunate to have a lot of funding over the years. Hopefully that continues. In our current state, we don't know, but we're just going to keep trying, and so grateful for all of our support. In terms of the learning objectives, since this is Grand Rounds, we're going to discuss the pathogenesis of NEC. I'll try to keep you awake for those of you that don't do basic science, and really want to talk about how we are working to prevent intestinal inflammation in premature infants, and certainly prevent NEC. And then there's a lot of new directions in the field, and we're doing a lot of effort that's going into biomarker discovery. And, sometimes it's really hard to translate from the bench to the bedside when you're going from mice to humans. And so some of our new model systems that we've developed and some new personalized medicine approaches. And because we all that work in the NICU, we see NEC or worry about NEC almost every day. I just got a text message about looking at an x-ray for one of our babies actually that has NEC. And when I give talks, I like to dedicate one of the presentations to one of the babies that has lost their lives to NEC. And so this is one of our babies at UNC that died from NEC, Titus, and they started this Titus Strong Foundation, and now they donate to our lab to help cure this devastating disease. And so for those of you that have never seen this before, maybe you haven't rotated in the NICU, NEC affects about 7% of all premature babies and is the leading cause of death from gastrointestinal disease in premature infants. And there's a lot of pediatric surgeons in the room. Thank you for all that you do. We, even with surgery, we see a mortality that approaches 50%, which is really devastating and hasn't changed, in the last several decades. We don't really know why NEC happens. We do have some clues into that, but there's a lot of healthcare costs and resources that go into this disease. Specifically, it prolongs their length of stay in the NICU for about 2 months if they've had surgical NEC. And really, the goal of our lab and the overarching goal of, when I was a fellow, and I'll talk a little bit more about that, but really the goal of our lab is to save the babies from NEC, and that's like our lab motto, and I'll walk you through that. So if you haven't seen the disease before, you have this premature baby that's just growing in their incubator, and then they get significant abdominal distension. And you can see this baby here. It may not project well from the back of the room, but there's some erythema around their umbilicus there. And histologically, what this looks like is this is normal human premature small intestine here. You see these intestinal villi here, and then in neck, and this is a baby from here actually, you see just obliterated intestinal villi. And so I said I would take you on a journey. So when I started pediatric residency, I didn't have any research experience. I was interested in neonatology, and it was actually a group of triplets that convinced me and their mom actually to go into neonatology. And so the reason I say that is I think, as you're a resident, you're trying to decide what you want to do with your life and what you want to specialize in. It really only takes one like patient or mentor or, set of triplets to really change your life and your whole career trajectory. And so it did. And so for me, I was interested in neonatology. At the time, Children's Hospital of Illinois, where I was, did not have a neonatology fellowship. So I was really fortunate to come here and to this amazing place with all of you amazing people and do my fellowship here. And so when I got here, you have to pick a research project. And I was just really excited to take care of babies and was not excited at all about research. And so, Jen and my division chief at the time, Gary Silverman, was saying, you have to pick a project, Misty. And I think I was the last person in our fellowship group to pick something. And I said, I'm not really interested in basic science. I mean, maybe, I don't know. I guess I could do anything for 2 years. And, but really my only clinical interest was neck. And it was because when I was a resident, I would take care of babies that would be fine. And then you go home and they had died overnight. And it really struck me that we had to do something for this disease. And I knew I wasn't going to cure neck during my fellowship, of course, but I think it was one of those things that I was at least excited to get up in the morning and try to fight the disease. And so, my fellowship coordinator at the time, Jan Walker, I would have been voted literally least likely to pursue a research career. And I didn't intend to be a physician scientist, but I'm really, really grateful for the opportunities that I've had and just really, incredible mentors and colleagues along the way, several of which are in this room. So thank you. All right, so the research overview of our lab is obviously dedicated to neck. And specifically, we're looking at the pro and anti-inflammatory responses that occur in the intestine. And what happens is there's a bacterial dysbiosis that several microbiome investigators have seen that happens either like 48 to 72 hours prior to diagnosis of neck. So there's this shift in their stool that, you have a bloom of dysbiotic bacteria, and we really want to know what's happening when that happens. And so is it an immune response to that bacterial dysbiosis? And a lot of it looks like it is, but we're trying to figure out why and how we can prevent it. And so there's so many knowledge gaps in the field, but that's one of the big focuses of our lab really is to figure out what's regulating that immune response, both pathogenic and protective, and then really develop these either novel nutritional strategies or immunotherapies, as Jen mentioned, and prevent the disease. And so I already mentioned our lab mottos, we're saving the babies from neck. And I did that mostly because we have a lot of undergrad pre-meds in the lab and they're like, what are we doing? And so, when they're feeding the mice, which I'll tell you about, I need to give them something to look forward to. And so really the vision is to build a world without neck. So we never have to take care of these babies that are going to get this disease. We really can't, as of yet, prevent premature birth, which is a major cause. And so we have to figure out why it happens. So we do that with mechanistic research and then again, novel therapies that we're trying to develop. And this really isn't going to be one of those diseases that, I cure in my lab or Dr. Tim Hand cures in his lab. It's going to be something that we all really need to work together. And the field historically had been pretty siloed. And so I've been working hard over the last 15 years, I would say, to break down those silos. And so I'll talk about some of those collaborations. And those collaborations are really important because we may see like 10 to 15 babies with surgical neck, for example, at one particular center. And it's hard to, be able to say with all the individual patient variation that happens, what is it that's really driving this disease? And so it's important to have large multi-center studies. And so I'll talk a bit about how we're tackling that. So one of the ways in which we do that is our mouse neck model. And anybody who's worked with animals before knows that when you have these model systems, you have to figure out what are the risk factors of the disease, and then how can you then recapitulate that in mice. And so this is a slide that shows all the different things that we think about that predispose our babies to get NEC, but including prematurity and dysbiosis, and of course their impaired immunity, but then also thinking, how can we model that? And so when you look at the cellular level, these are some schematic of the intestinal epithelial cells here. These are dead intestinal epithelial cells. What happens is the gut gets leaky, and a lot of us have already heard about leaky guts. It's like in the main press. And but this dysbiosis that I was talking about that happens, you have these gram-negative bacteria that are present in the lumen of the intestine. And what can happen is they have lipopolysaccharide, or LPS, and that can bind to this innate immune receptor, toll-like receptor 4. And all you need to know is what happens is then downstream of that, there is this significant cascade of pro-inflammatory markers that are released and inflammatory cells, et cetera, and then you get epithelial cell injury. And sometimes what we see at the bedside, for example, is you have a baby that looks like they're in septic shock, and that is oftentimes because you have bacteria that are present in the lumen and get past this gut barrier and then cause that like systemic sepsis like picture. And so one day I was sitting at lab meeting and, trying to figure out what I was going to do with my fellowship life. And my mentor was like, you have to learn how to feed mice. And, I was a neonatologist. We like small things, right? Or neonatal fellow. And, but I had to learn how to feed mice. So I put this in here. We're going to talk a little bit about mice. It's going to be fun. Don't get too bored. But I'll show you how we feed the mice. This is a picture of a neonatal mouse. We take a neonatal PICC line shown here and feed them a mixture of puppy formula and then term infant formula, mix it with that lipopolysaccharide that I talked about, and then add the microbiome from an infant that had Necrotizing that one of our surgeons, maybe in this room, operated on several years ago. And we have, really cultured that and over time and done a lot of analysis on it. And it's this real dysbiotic microbiome that without the presence of that human microbiome in this model, the mice don't get sick. And so you can see here, this is just some pink intestines from a mice that is just breastfed. This is the intestines of an animal that was subjected to the model. And what we do is we take 4-day-old mice and then hand feed them every 3 hours. We have an army in the lab that does this. So a lot of them are pre-med, and it gives them something to talk about on their med school interviews. And so our team feeds the mice from 7 a.m. to 10 p.m. at night. And then we subject them to hypoxia twice a day, 5% oxygen to really stress the gut. And then we euthanize them on the 7th day and then look at their intestines. And so just to give you some framework of that, when I was a NICU fellow, we had to figure out a project, as you know. The only thing we really knew about, at the time about NEC was that breast milk is protective. And so once I picked a lab, which is David Hackham's lab, who's a, amazing surgeon scientist that was here for a long time, we knew breast milk is protective. And he said, okay, let's go figure it out. And at the time, it's a very ambitious project. I highly recommend not tackling something that people have been trying to do for 40 years as your fellowship project. But at the time, I was very naive. And so breast milk is protective. We wanted to know why. There's so many great things in breast milk, and we chose to focus on growth factors. And so our hypothesis at the time, we know breast milk is protective. We want to know what's in it and why. And so we focused specifically on epidermal growth factor, or EGF, and EGFR signaling, which is the receptor. And the reason we did that is because there was a lot of really great research coming out at the time that EGF is protective in the gut for inflammatory bowel disease, et cetera. And we thought that would be great for NEC. And so I was sitting at lab meeting, again, in this exact building. And, I was tasked as a, second-year fellow, go get some breast milk from mice. And when I'm like still learning to pipette and all the things that I didn't know how to do. It was a huge task. So this was a major barrier to my fellowship project. I'm not sure Jen knew I was going to actually get anything out of it. And so it took me a long time. I had a backup project and everything that luckily we published first before this, my fellowship project. But I'm going to show this video here. We finally published it several years later because after some people heard about it, they wanted to know how to do it. And it's not hard. I just like rigged a human breast pump to be able to do it. But it took probably 9 months of my fellowship. So I'm going to play it here just so.
Fitted with silicone tubing sized to fit mice and a 5 milliliter tube. Extract milk from the teats one at a time. Finally, aliquot the milk immediately.
Okay, and if you missed it, there's a non-sterile picture of the mouse that's getting their breast milk extracted. And so when you think about the small amounts that we're getting from these mice, and we have to then feed their pups or gavage the breast milk back, it makes for a really difficult fellow project. And so, I'm just going to go over this briefly. What we did, we subjected our mice to the neck model. These are the histology slides here. We, instead of giving all of their feeds, that was a mixture of formula, we gavage some of that breast milk, the mouse breast milk, back to them. And you see that there's preservation of the villi there. And then we wanted to see what's the mechanism by which this breast milk is protecting. And again, we were focused specifically on epidermal growth factor. So there's an EGF receptor inhibitor called cetuximab, or Cetux here for short. So what we did is injected the mice with cetuximab to block that EGF receptor signaling, and you see you lose the protection there. We then wanted to take the breast milk that we milked, got from the mice or extracted from the mice, and then depleted the EGF out of the breast milk. So that's immunodepleted breast milk, and you see you lose protection, and then you can add it back with recombinant EGF, and you see that breast milk attenuated the inflammation there. Then in mice, of course, you can knock genes out. And so we knocked out EGF receptors specifically in the intestinal epithelial cells. And we see that those animals are susceptible to NEC. And then when we added breast milk to their formula, they were not protected. So suggesting that one of the ways in which breast milk protects against NEC is via EGF and EGF receptor signaling. And we wanted to see if this is important in humans. So when Jen was talking about the NEC biorepository, which started in 2017, it really started all right here when we were getting a lot of intestinal specimens into our lab. Thank you to the surgeons, specifically Dr. Mullen, who was giving me surgical resections for a long time, since 2009. And we wanted to see what was the EGFR expression in NEC in humans. So this is premature fetal intestine at 23 weeks, back before we resuscitated 23 weekers. So you can see in red, these are confocal images stained for the protein EGF receptor. You see nice red staining there. In the context of NEC, you see that this EGFR staining, the red, is significantly decreased. And from the same baby, we got intestine at the time of reanastomosis, or healed NEC, we call it. And you see that protein is restored. So suggesting that decreased intestinal EGFR expression is associated with NEC in humans. And so that's great. It's a nice story, certainly fellowship project that came to fruition. So I could actually pass fellowship. But we know breast milk is protective, but it's not enough. And one of the things I would say when we're trying to translate from the bench to the bedside, EGF is awesome, and we would love to use it in our babies, except that excessive EGF receptor signaling has been shown to be associated with head and neck cancers. And so when we think about what we're doing and we're enhancing, proliferation of the gut, and I didn't have time to explain all of the things that we found that EGF does, but you want to make sure that you're not doing harm long-term. And so we had to certainly pivot a little bit, and there's a lot of great folks working on precision nutritional strategies, and hopefully in our future that is there to come. And so I'll talk a little bit about novel therapies, but at this time I'll give you like a career update. So I graduated fellowship, as you know, thanks to Jen, and then I had stayed on as faculty here. I got a KO8 And at the same time I got a KO8, my mentor and the entire lab left. And so, so it was a devastating time for me, actually. And I really had to figure out, am I going to stay in science? What am I going to do? And I'm pretty resilient, and so decided to stay, but I did need to pivot. And so thinking about everything I'd learned before and, breast milk obviously being very important, we decided to focus on cytokines. And luckily, my mentorship team, I had an incredible mentorship team here at UBMC, and one of those people that I'm deeply grateful for is Jay Coles. So he adopted me into his lab as a junior faculty member. And he's for those of you that haven't had the pleasure to know Jay, he's a Th17 expert. So IL-17, IL-22, T cells, mucosal immunology, and basically did a second postdoc with him on mucosal immunology. And it's a big focus of my lab currently. And so deeply grateful. So when I had to pivot, we had to think about, what is going on in neck and what do we know? And so specifically, we knew that neck, there's gut barrier dysfunction, as we talked a little bit about. There's also intestinal stem cell loss and really impaired mucosal healing. And there were all these great studies coming out at the time in Nature and other amazing journals that there was a critical role for interleukin-22 or IL-22 in intestinal stem cell regeneration. It regulates gut barrier integrity in adults, and then can attenuate intestinal inflammation and enhance antimicrobial defense. And so this sounds like a great option for neck, and we chose to pursue it. And one of the first experiments that we did here is these are little mini guts or intestinal organoids, what we call enteroids. And if you give IL-22 to these little enteroids, and other great labs have done this as well, they get big and they grow. And so we'll look at that. And so we wanted to see first what's happening in the neonatal condition, both in mice and humans, with IL-22. And so we all know that neonates have impaired immunity, but wanted to see specifically about IL-22. So this is work that was done by a postdoc in my lab when I was at WashU, Ben Meehy. And so what he did is look at across the mouse lifespan from embryonic day 15 to postnatal day 49. And mice, just for those of you that don't think about them all the time, they are weaned between P21 or postnatal day 21 and 28. And so what's happening during that time is they're going off breast milk and they're going on, mouse chow diet. And so this is just looking at the gene expression of their small intestine. And so low IL-22 expression until weaning. And then this is just looking at flow cytometry at 1 week old and 8 week old mice at the CD45 positive expression of IL-22. And so we then wanted to look in our mouse neck model. So this is some histology from that. And then looking at the intestine and the IL-22 expression was decreased. And then in the human situation, it was interesting. We thought, okay, well, maybe it'll be decreased as well, but it really wasn't in this small cohort. And so we thought, okay, well, if in human babies, they can't mount an IL-22 response, either up or down, what if we gave it as a therapeutic? And so that's what we did in mice. And so this is some histology from those experiments. So these controls are breastfed animals that were given either recombinant IL-22 or saline, PBS. And in the animals that received the recombinant IL-22, you see nice preservation of that intestinal villi and the architecture. And when we looked at the cytokine expression, mRNA and protein, you can see that the IL-22 attenuated that pro-inflammatory response. I was talking a little bit earlier about some proliferation. This is a picture of that. And so PCNA is proliferating cell nuclear antigen, shown in green. And so nice proliferation is healthy. So you see that that's pretty diminished here in the animals that were subjected to NEC. And then in the animals that receive recombinant IL-22, that green is nice and restored. And this is where a lot of the stem cells live in the crypts of the intestine. And one of the things that we've been working on a lot over the years that we haven't published, but I put here just when you're trying to think about, going from the bench to the bedside, what do you need to do? And so we've done a lot of preclinical studies for the FDA looking at different doses of IL-22 and what that does in our mouse model. And so if you look here, these intestines certainly look a lot better than these in our mice, and the histology is shown here. So a lot of these histologic pictures look great. Certainly the highest dose looks awesome. But actually the FDA is really interested in like, what is the minimal effective dose? And so we're doing a lot of preclinical studies to try to get this into a clinical trial, and more to come on that. We're working on it, a pre-IND. And so just a little interim summary. So we know that IL-22 expression is low in the developing in mouse and human intestine, and that treatment with IL-22 can attenuate the intestinal inflammation that we see in NEC. And again, we have a patent on this, as Jen mentioned, and so hopefully more to come. But I want to shift gears a little bit and talk about collaboration. So it's nice that we can do all these studies in mice, but it's really important that we think about what is happening at the bedside and what are we seeing in the human condition. And so again, I started in 2009, biobanking, and I was sitting at lab meeting one day, and my mentor was like, I need you to go get some samples from some babies. And as a second-year fellow, you're like, okay, well, that's a lot of work, number one, and I already have a big project, but it needs an IRB, right? And so he's like, yeah, go write one. And so, I try to be a better mentor over time to my team, to be like, I will support you through it. But I will say it did teach me a lot. And now, I'm teaching other people how to do it, which is really incredible. So we started biobanking. I started biobanking back then, but recognizing that, again, one center, you can't do everything. And so I helped a bunch of my friends who are NEC researchers do this. And so we collect all kinds of samples from all kinds of babies, and I'll tell you about, but really the purpose is to help facilitate and really accelerate translational research. And so our job really is to help assure the quality. So, some of these specimens are dying, like obviously inside the baby, and they're definitely dying as soon as they leave the operating room. But it's not just intestine that we bank or analyze. We collect blood, urine, stool, gastric aspirate, saliva, breast milk, and certainly intestine. And in 2017, I partnered with the NEC Society, which is a patient organization that's focused on NEC. And, there's a great group of people that are really dedicated to this disease. A lot of them are part of the biorepository. I'm trying to get Dr. Hand to, I put this in here for you, trying to get Dr. Hand to join so I can put, the Pitt, little logo on here. But really this biorepository is trying to accelerate research for NEC, and we're really grateful for all the funding that supports this initiative. And Jen mentioned the Chan Zuckerberg Initiative Award. So one of the things that we're doing with them, with the biobanking, is with the research team here, with several sites across the nation, is we're building a single cell atlas across development and NEC. And so this is Scott Magnus, one of our collaborators. And so we're looking prospectively across all the gestational ages, all the different cell types in the gut and the stool, and certainly other bodily fluids, to see, is there a clue that can tell us about this disease? And so other biomarker things that we're doing, we collaborate with David Peters, who's an incredible PhD scientist here. So the next several slides are going to be from my collaboration with him that I'm really grateful for, and happened when I was early career faculty here. And we share an R01 on this work. Go back one. So what we did is we took samples from the operating room from babies with or without NEC, so controls or NEC, and then he is a genomics expert and knows a lot about epigenetics. And so there's a lot of work that was going on at the time, what is happening at the genome level and what different exposures are happening to our babies that can predispose them to this disease. And so this is just a case control study looking at, the most severe babies, and is there a difference, and is there a phenotype? And so what we found is that there's global DNA hypermethylation in the babies that have NEC that were resected either colon or ileum. And these heat maps are showed here. So dark blue is the hypermethylation. And so this is just, again, like a very high level view. But we don't want babies to get surgical neck. And so we want to really see what can we do and how can we detect this sooner. And so we looked at stool from babies with or without neck and looked also at this methylation. And so you can see that, again, there's stool DNA hypermethylation in babies with neck. And I mentioned we get all kinds of samples from babies. And so a postdoc in the lab, Stephen Mackay, was interested in looking at, okay, if we're using all these multi-omics, let's look at some other aspects. And so he wanted to see, were there differences in the serum of babies with and without neck, and just high level. And so he looked at this, did proteomics on the serum of these babies, and found that there were just 11 actually serum proteins that were significantly different in the cohort between neck and controls. We now have a grant that's looking prospectively to see, can we detect these differences? And we collect all the clinical data from babies with and without neck prospectively from the ones that we enroll in our study. And we have over 850 babies total enrolled. But we're trying to see, what is it? Is it something we're feeding them? Is it some other exposure, some medication exposure, et cetera, that could be changing the epigenetic makeup or the protein makeup of their samples? And so what Stephen went on to do is to look at, for the babies, we always say like age match controls, but a lot of those babies in the NICU have different exposures. So a 24-weeker is, if they have neck or don't, is going to have different exposures than another 24-weeker. They're not true controls. So we looked at self-match babies. So babies, again, prospectively, that we had samples for before they got neck and then when they developed neck, and looked at different proteins. And so we have several ongoing studies that are digging deeper into this, and hopefully more to come. There were these patterns that we noticed, and so we're trying to see, can that correlate? And is this something that we could then test at the bedside for, so that our nurses can clue us in sooner that the babies have neck? And we're throwing these diapers away all the time, right? And so one of the things that we wanted to see is, before we throw those diapers away, can we get some urine or some stool? And so we put a little 2x2 in the diaper and collect urine for a lot of studies, including proteomics. And one of our newer studies, because urine's so easy to collect, but actually there's a huge signature in urine. And so we're digging deeper into this. So when we looked, there were 2 urine protein panels of interest. Interestingly, these proteins here, these reg proteins, are IL-22 dependent, and so we're looking into that more. But we wanted to publish it and start getting people thinking about it, and really digging into that as well. And one other aspect that is going on in the lab, there are these organ chips. And so instead of those little mini guts or those intestinal organoids that I talked about previously, we are really trying to get at, you can do so many things in mice and other animals, of course, but that doesn't really translate into what's happening in a premature infant. And so what we do is, with the resected intestine that we get into the lab, we can then grow up, and I'll show you some pictures. We can grow up infant intestine on these organ chips and then test various therapies. And so this is a schematic of what that looks like. So we get intestine into the lab, isolate the crypts, and then do some cell culture with various growth factors, including EGF and others. And we grow up this is a well with these little enteroids. And so once we have these enteroids, you can dissociate them a bit and then put them on the chip. And then what the chip is like, if you take a cross section of it, you have the epithelial cell chamber on top, you have the endothelial cell chamber on the bottom, and then you have this extracellular matrix coated membrane here, and allows crosstalk of the epithelial and endothelial cells. And this is what one of the machines that we use for this looks like. So this is a chip. This is their chip house that you put them in. And you can do various things with them. You can feed them, you can give them formula, you can give them breast milk, you can give them anything you want. And so this is where their media goes. And when these chip carriers go into this machine here, what happens is that there's continuous media flow to the chips. And then this machine here called the orb then stretches the chip. So that mimics gut peristalsis. And so something that we can't do in regular cell culture because it's just stagnant. And one of the cool things about this is that you can give, microbiome to these chips and then you can culture them long term. But in regular cell culture, if you do that, the bacteria are replicating and then your cells are destroyed, soon after that. And so this is what it looks like under a microscope. So these are little pictures of our premature infant enteroids, and then we dissociate the cells. This is what they look like on day 1, and this is the chip and that membrane that I talked about. And then by day 3 of, being in the cell culture module, you see this neonatal epithelial cell monolayer that develops. And so nice monolayer there of cells. And then by day 6, again, with that stretch, you see that you start to get these little valleys right here. That's really the beginning of an epithelium starting. And I'll show you some cross sections on the next slide. But you can see here, there's these villus-like axes. These are like 3D structures. And so we were really excited to see this. And this is work that was really pioneered by a technician in my lab that was pre-med and now just matched into adult, unfortunately, endocrinology, Wyatt Lonick, but he's absolutely incredible and is going to nationwide. And so this is a cross section of what that looks like. And so if you think about the intestines, the schematic over here, these are some epithelial cells and goblet cells and other cells. So this is a cross section of those 3D villus-like axes. So you can see, how those look and all the different, I'm not showing all of them here, but all the different cell types are present. So a lot of colors there. And one of my mentees, Lauren Frazier, was working with one of the postdocs in the lab. And again, you can see this here. They did some staining to look at specifically goblet cells because we're really interested in goblet cells. And I don't have time to talk about it today, but how can we modify the mucus of the gut to make the gut healthier for our babies? And so so she's doing a lot of this work related to goblet cells. But that's fine. We can grow them up on the chip, but how can we then model NEC on a chip? So NEC, as you know, is this very complex disease. And when we're thinking about cell culture, we're thinking about, this reductionist approach. And so what can we do? So we grow up the neonatal intestine on the chip. As I mentioned, you can do various things, including seed the chip with microbiome from particular patients. And so we did that with that same baby that I talked about that was here, I think in 2012. We basically got a piece of intestine from the lab and then cultured this enteric bacterial slurry from that particular baby. And so what we did, and I'll show you some data, but you can see over the next few slides that this model upregulates pro-inflammatory cytokines, which we see in the human condition, and then reduces intestinal epithelial cell proliferation, and then also disrupts the gut barrier integrity. So I told you about the gut barrier being critically important. And so we really wanted to be able to model that. And it's harder to do in cell culture. And so we wanted to look at humans, obviously, first, and look at different epithelial cell markers, pro-inflammatory cytokines, and stem cell markers, and then compare to our chip. So this is gene expression data here looking at LGR5, which is a stem cell marker, MUC2 is a goblet cell marker, lysozyme PANA cell marker, and chromogranin A. And so we looked at those. A lot of those are decreased in NEC, and then pro-inflammatory cytokines, IL-1 beta and IL-8 are critical in NEC, and one of the markers that we always see that goes up. And then looking at proliferation markers like proliferating cell nuclear antigen that I talked about earlier, and then Ki67, which is another proliferation marker. And in NEC on a chip, so we have our control chips that are just treated with media alone and grow normally, and then our NEC on a chip where we administer that human microbiome. And you see a lot of these epithelial cell markers are decreased, and the pro-inflammatory markers are up, and the stem cell markers are down. And you can see that at the protein level here. So looking specifically at those different cell types. So enteroendocrine cells, again, it's chromogranin A, proliferation, Ki67. These are all shown in red. And then Panna cells and goblet cells. So in human control intestine, you see nice healthy cells. And then in neck, you see a lot of those cells are decreased. And then in our neck on a chip, you can see that that recapitulates a lot of what is seen here. So you see nice healthy cells in the control, and then just barely any of those cell types in the neck on a chip. And then when I talked about the gut barrier, so we wanted to see the different tight junctions that are between the cells. How can we break those down? And does that happen with this addition of the dysbiotic microbiome? And so these are different time points of the chips. This is zona occludens 1, which is just one of the tight junctions, but shown in green here. And you see in the neck on a chip, you see that those are significantly breaking down at 24 hours and are totally gone by 72 hours. And it's nice to see pictures, but we really wanted to know, okay, what else is going on? Because we can't do one gene or one protein at a time. And so we did RNA sequencing on the chips to see what are the different pathways, for example, that are up and down regulated, and saw that there's a bunch of the cell death pathways, so apoptosis, necrosis, ferroptosis, and others. And a lot of the cytokine signaling pathways are certainly upregulated, which we would anticipate in both 24 and 72 hours. And this is work that was done by a NICU fellow that was in the lab, Lila Nolan, who's fantastic, and now a neonatologist at WashU. And so I want to leave time for questions because there's certainly a lot to talk about, but we're really excited about neck on a chip as a promising new patient-derived model of neck. We know that it's recapitulating several of the features that are seen in human neck. The platform that I showed you does just 12 chips at a time in one machine, and we have a couple of the machines, so we can do like 24 chips at a time, which isn't that high throughput actually. So I just recently invested in a new platform that can do 64 chips at a time, which is really exciting. And we have the opportunity to really test like drug discovery and like what is happening if we give a drug to our babies, what's happening to their intestine. Some of us worry about everything that we give orally. For example, like if we put a baby on sodium chloride or diuretics or something, what is happening? And so we now have the exciting ability to be able to test that now, which I'm really grateful for. And so we're continuing to do these personalized medicine approaches and certainly continued biomarker discovery so we can hopefully get an answer. And so, science is hard. And so I put this here, just no matter what, keep fighting on. And if you're not doing science, one of my mentors once told me, why just save one baby when you can save them all with your research? And I really think that that's truly profound. And we have the ability to make a difference. And something that is important to remember, that our patients and our families depend on us for hope. And this is a baby that died from the founder of the Neck Society and looks fine on nasal cannula, right? And then got neck and died from complications of neck. And so I put this here. I really miss all of you. And if you want to collaborate and help us save the babies from neck, we're open to that anytime. And then Jen mentioned the Incubator podcast. So this is a shameless plug, not for me, because I'm not on it all the time, but we were practicing being podcasters because, that's not really my jam. And so anyways, we have this neonatal physician scientist podcast. There's 3 of us that run it because we're all running labs. But it's, to try to make sure that people know that being a physician scientist is fun, and we are great, and we're trying to save the world. And so check it out for NICU fellows. If you haven't checked out the Incubator podcast for board review and things like that, it's obviously great. And then I have a really incredible team of people that none of this would be possible without them. And our collaborators and funding sources are just truly amazing and very fortunate. So thank you very much. Happy to take questions.